Hello, students. Good evening and welcome to this recall session. And I hope your exam went well. When I was looking at the dermatology questions, I felt that they were quite easy. We had discussed them a lot of times, and they were mostly from very high yield topics. So I hope you felt the same, and I would be willing to get your opinion on that, and you can share with me that how did you fare well in your dermatology questions. So before I move on to the exact questions, this is, as you all know, these questions that we will be discussing are all recall based. And the only motive of this live session is to get actual questions from you that were asked in the exam. And we will upload the final questions once we have them after the discussion. Also, this is a recall session. And so maybe the options that I'm going to show you, the question or the image that I'm going to show you may not be what you got exactly in the exam. And that is where you will help me out. So don't mark yourself based on what I give as answers, but because probably the answers, the options, the image, or the question was something different, right? Great. So derma was easy. I'm glad to hear that, Dr. Zishan. I also felt that derma was easy. I did not find any question which was like out of the way. And you got quite a lot of questions in dermatology. Sometimes they're just 4 to 5 questions, which make me feel sad because it's such a high scoring subject. But today you had good number of questions. And also, if I miss out on any questions, you're more than I'll be more than happy to receive them from you. So, moving on to the first question, an elderly female undergoing chemotherapy for breast cancer is experiencing significant hair loss. What is the most likely cause of her condition? So, was this the question? May not, may the image may not be the same, but I think approximately it would have been the same question. So, very clear-cut question. Patient is on chemotherapy and has presented with significant hair fall. We all know chemotherapy kills mitotically active cells, and so the phase of the hair which is actively growing, which is my anagen phase, gets affected when a patient is on chemotherapy, leading to loss of hair in anagen phase, which is also called as global alopecia, because anagen phase constitutes 90% of the hair. So when a patient is on chemotherapy, the type of hair loss that happens is called as anagen effluvium, because it is this phase which is mitotically active. Great. So same question, anagen effluvium, you all marked it right. I'm so happy to hear that. Great. So moving on to the next question. Again, I think a very simple question. Which of the following test is most appropriate for diagnosing this condition? So probably you were given an image of psoriasis patient and you were asked what bedside test would you perform to diagnose this condition, right? That's okay if you wrote telogen. So there are other questions where you will score. Don't worry. Right. So I've moved on to the next question. Any inputs on this question or the options? So probably there was an image of a psoriasis patient. The bedside test that you do in a psoriasis patient is either Grattage test or Auspitz sign, which is what you do with a glass light. I'm sure image would be different, Dr. Amim, because obviously we would not know the exact image. This is just to give you an idea that probably there was a psoriasis image which was provided to you, and I'm sure you would have easily diagnosed that. So when you have a psoriasis patient, the bedside test that you do is called as Grattage test or Auspitz sign, where you take a glass slide and scrape off the lesion and you see increased scaling. Then you see Berkeley's membrane, and then you see pinpoint bleeding points. All the rest of the options which I have been provided with are something that you use in patients with immunobullous disorders. So Nikolsky sign, Zank smear, or Esbo-Hansen test, which is a variant of Bulla spread sign. These are all utilized in immunobullous disorders. Only Grattage test or Auspitz sign is the correct option here. Okay. Images were almost same. Looks like psoriasis, Grattage, yes. Okay, so Dr. Amim is telling me Grattage or Auspitz both were there. So in case you had both Grattage and Auspitz in the option, then you should mark Auspitz sign. because I have told you Gretard's test is just a part of Auspitz sign, and it is Auspitz sign which covers all the three parts of the test. If both of them were there in the option, then Auspitz sign would have been a better option, but I'm not sure whether they give you both the options or either of them. Right. So if other people could also help me out here. Okay. So only Auspitz was there. Can you explain A option? Yes, Nikolsky test is Nikolsky sign that you do in immunobullous disorder, where you put a shearing force on the normal skin surrounding the bulla, and that skin shears off or forms a blister or a little erosion. That's used for immunobullous pemphigus group of disorders, right? If patch test was also mentioned, still the answer holds the same, because patch test is something that you use in contact allergic dermatitis, not in psoriasis. So that's okay. So if Auspitz was not there in the option, probably Gretard's test was there in the option, right? So I think one thing we are clear on, that there was an image of psoriasis and you were asked a test, and most of you were saying that Gretage was only there. So that's okay. Gretage test, Auspitz sign, whatever was there, you can mark that. If both of them were there, then I told you Auspitz sign would be a better option. Great. So if no Auspitz was there, Gretage would have been the correct option. Now, moving on to the next question, which I have here. A baby presents with chronic diarrhea and a rash resembling ectodermatitis on the skin. Based on the clinical picture, what is the most likely deficiency? Again, a very giveaway question. You have diarrhea and then you have ectodermatitis. Probably you were provided with images which showed periorificial or perianal eczemas, and you know that this is called as acrodermatitis entropathica, which happens due to zinc deficiency. Yes, very easy one. So great. So I hope there is no controversy on this question, or is there any picture was there? 2 seconds and answered. Move on to very good, good. So I think there is no controversy here, and you all are quite clear about the answer. So I'll move on to the next question. A neonate presents with a growing skin lesion, as shown in the image provided. Mother reports that the lesion has been increasing in size daily. What is the appropriate management? Now, here I would need help with you, whether okay. So, what was the image which was provided? What was that? An image of an infantile hemangioma? If it was an image of infantile hemangioma, you should know that the course of hemangioma is that it grows in size till 9 months of age, and after that, it starts regressing. So, usually, if a child has an infantile hemangioma, you just do counseling and you observe the child. Unless your hemangioma is at a site which is affecting vital function of the body. Yes. Okay, great. So if this was the picture, these were the options. We'll definitely go with the observation here, because see, the site of hemangioma is on the abdomen, not covering any vital area like nose or eyes or ears, which can affect the vital functions of the neonate. It is given that this was a neonate. So at this stage, hemangioma would definitely grow. Hemangioma stops growing and starts regressing after 9 months of age. During that time, you only observe it. So you only keep the patient under observation. Okay, so skin grafting was also mentioned in the option. Even if that was mentioned, that will not be my treatment of choice. Even if I have to treat hemangioma, so suppose you got confused whether treatment should be done or not. So the treatment for hemangioma is steroids and propranolol, which is not there in the option. So none of the other things are done in a neonate. Okay, 3 weeks old neonate, perfect. So again, proves our point, right? Great. So I think again we are clear on this question. We have a neonate and there was a hemangioma on the abdomen. And believe me, if there was no option of steroid and propranolol, there was no point of getting confused, because that is what you do for hemangioma. Right. Now, this is a question which I feel is incomplete for me to answer, so I would need your help. Now, the question says, what is the most appropriate treatment for acne? Now, what kind of acne was given? Was this the same image which was given? I would need help with you. Or was the question, what is the treatment of choice for acne, or what is the best treatment for acne? Can you help me out here? Because then the answer changes, because we know acne is treated based on the grades of acne. So if only this image was given, here I can see just whiteheads. So predominantly comedonal acne, which is my grade 1 acne, which I will treat only with topical retinoid. Great. So patient, probably you had nodulocystic acne. That helps me. Great. Acne present over face. He has a lot of acne, severe acne, nodulocystic acne, acne, or just was just isotretinoin stage. So if the option was just isotretinoin, remember isotretinoin does not come in topical formulation. You get topical retinoids, they're different. But isotretinoin is oral retinoid only. Okay, was there, ma'am, 10 years of acne oral? Okay, great. So thank you so much. I think I got what I was looking for. So I understand this is an incorrect image. You had been provided with an image of nodulocystic acne, which had been persistent for many years. So in this case, obviously, my answer would be oral isotretinoin. Even if oral was not mentioned, please remember, students, isotretinoin is only used orally. Okay, there was no mention of oral or anything, just isotretinoin. Still, if isotretinoin was given, isotretinoin is a oral retinoid. There are two oral retinoids that we commonly use, acitretin and isotretin. Isotretinoin we use in acne and acitretin we use in psoriasis, right? So if they had mentioned nodulocystic acne, answer would be isotretinoin. That's okay. Or acne, right. So, and you also are telling me that acne is present on the back also. So probably there was truncal acne. So such an easy question. We've discussed all of this. Nodulocystic acne, we all know the treatment of choice is isotretinoin. Thank you so much. Acha, topical steroids were also mentioned. Yes, it's mentioned here also. Obviously, you know that's not an answer unless you want to give the patient drug-induced acne or acneiform eruption, right? Great. Thank you so much. So, next question was again very easy. What is the incorrect dosage of leprosy medication in adults? So, was this the same question? And if it was quite easy, you know that the leprosy medication in adults, you give 600 milligram of rifampicin once a month, not 450 milligram. 450 milligram you use in children. Rest of the dosages are correct. Great. So was this the same question? No confusion here, I guess? Correct dosage of leprosy medication in adults? Yes, in week. Acha. It was once a week. Okay. Thank you so much. They had asked you multibacillary. See, multibacillary and paucibacillary does not change the picture anymore. You gave the same regimen, 6 months for PB and 12 months for MB. Right. No confusion in this question, but probably you've given 450 milligram of rifampicin once a week. So both of this becomes wrong. The dosage of rifampicin is 600 milligram and it is given monthly. Clofazimine 300 milligram monthly and 50 milligram daily, and Dapsone is 100 milligram daily, just weekly, whatever. So the dose was 450 milligram, which is the incorrect dose, right? So no confusion in this question. I am so glad you had no I hope you had no confusion in all the questions. Okay, so this is again a very clear-cut question. I've been repeatedly telling you in my lectures that they're very, very fond of basal cell carcinoma. Every FMGE exam, they have to ask you BCC. I don't know why. But a 60-year-old person presented with ulcer on medial canthus. Ulcer had rolled out beaded margins. Histopatch shows nesting cells with peripheral palisading pattern. I don't even need that. If I have been given a 60-year-old patient, medial canthus, ulcer with rolled out beaded margins, the only answer I know can be possible is basal cell carcinoma. In fact, with over the years, I feel if you get any question which is mentioning all these carcinoma, they would be asking you about BCC only. Somehow it has become the examiner's favorite. Okay. So they had not given ruled out. Pearly white margin was there. That then also nothing changes. Pearly white margins. Anything else in this question which was not correct? No ruled out. Same language. Pearly white margin. Oh, did they say keratin like pearls? I am not, I don't think so. If they had mentioned keratin like pearls, then the situation will become different because keratin like pearls is only present in SCC, right? But here I don't think so. They had mentioned keratin like pearls. There was description of BCC. Okay, so I think different sets may have some different questions. So one of you is saying that they've given you a description of BCC and they had asked you what would you see on histopathology. There was something in one question regarding. So maybe there were two different questions. You're right. If keratin pearls is mentioned, it would be SCC. In BCC, you do not see keratin pearls usually. Probably they give you a question on BCC and asked you what will you see in histopathology. Okay, so thank you so much for clarifying. So probably there was a different question on SCC which had mentioned about keratin pearls. Two different. So please don't get confused. This is BCC, and if keratin pearls was given, then you can say that it is SCC. So a lot of you are telling me that there were two different questions, and that I think clarifies our problem. C foam C. Acha, BCC was described. So even if they had asked this, then you know palisading pattern. And okay, great. So should we move on to the next question? So you told me there was a different question on SCC. Right. Temsilon was no man. Okay. So I think there is a lot of confusion with this one. So pearly white beaded margins with an ulcer present on medial canthus should be a BCC. In keratin pearls, if for your level, for I would say for the exam purpose, keratin pearls are a feature of SCC. In BCC, you see these nestling cells, you see nest of cells with palisading pattern, right? Okay, so I'm moving on to the next question. So a 30-year-old female presents with painful ulcerated lesions on the vulva with bilateral lymphadenopathy. Was this the exact question? Because I feel that there is something missing here. Let me see. Bubo was there. Only one question. If they had asked about BCC, yes, you will mark palisading. Okay. So was this, now we are moving on to the next question on genital ulcer. So here you have multiple painful ulcerations with bilateral lymphadenopathy. The most likely diagnosis can only be chancroid. Neisseria gonorrhea presents with discharge. Granuloma inguinale, which is donovenosis, has no lymphadenopathy. Lymphogranuloma venereum presents with buboes, painful buboes, but there are no ulcerations seen. So here the answer would be chancroid, right? Any confusion on this question? Painful ulcers with bilateral lymphadenopathy. Okay, sorry, I missed on the chat. Painful, indurated. Bubo ka clinical scenario, both painful also. Lymphadenopathy was there. Tender, indurate. Was induration mentioned? Because chancroid is not indurated. Bubo was there, but I may be wrong. Indurated, painful. Chancroid is not indurated. Chancroid is painful, but it is not indurated. A female developed above lesion. There was granulation mentioned. Beefy red ulcer and painful. No, ma'am. Same question. The describe about BC purpose. Some scaly-like lesions on penis and chin of cheek. Okay. So this is what happens in recall sessions, and I can totally understand. I am sure you're telling me with the best of your memories, but yeah, that can happen with the I getting different opinions on same questions. Two key points. So yes, that's what I also heard, that there were painful red ulcers and lymphadenopathy. If that was there, chapter closed, it's chancroid. If they had not mentioned ulcerations and they had written painful buboes, then you would go with lymphogranuloma venereum, right? So otherwise, it should be chancroid here. Okay. There was a question on lichen sclerosis with pigment on chin on tongue. Please, can you clarify? I am not able to understand. And there was also a question of some scaly like lesions on penis and chin of cheek. Chin of cheek. So indurated ulcer is only seen with syphilis. Donovanosis can present with beefy red granulomatous ulcer, which can have some induration at base, but donovanosis ulcer is usually not very painful and does not have lymphadenopathy. So, ma'am, then the question, patient with penile dull lesion also in the oral part. What is this? One of the option was lichen sclerosis. What lesion was? So lichen sclerosis can present in oral mucosa, but it's not very common to see it. So can you clarify what was the question on lichen sclerosis? So if they had mentioned indurated ulcer, then they would have either asked about syphilis or they would have asked about donovanosis, but then there would not have been any lymphadenopathy. There is no painless indurated ulcer with lymphadenopathy. Okay? There is no painful indurated lesion with lymphadenopathy. A patient presents with loss of sensation in posterior surface of the ear along with the lesion. What structure is most likely involved? So I am not sure whether this was the same question. Obviously, if there is loss of sensation, there has to be a nerve which has to be involved, and that would be greater auricular nerve. But was this the exact question? Yes, greater auricular nerve, because they're telling you there's loss of sensation on posterior surface of the ear, and we know that greater auricular nerves runs here. In fact, this is the nerve in leprosy which is more clearly visible, and you do not really have to feel it. Picture was there. Okay, so there was probably an image. And what did that image show? Was it an image of leprosy patient? Oh, so there was an image where tube-like structure was marked. So probably, so if you remember our lecture, I had shown you that the greater auricular nerve is easily seen. So you just turn the neck like this and you can see a tube-like structure. So if that was mentioned, then it was probably a more clear cut to you and it was greater auricular nerve. Great. So that is all the questions that I have, and I'm willing to know further questions from you. So I think some of you were mentioning about a question where there were some lesion in the penis and something in the oral mucosa. I hope it was not FD or something, some fixed drug eruption, or it can be erythema multiforme. It can present with oral ulcers, penile ulcers. Lichen sclerosis usually would not present with oral lesions. So lichen sclerosis can present with genital lesions. You see white lesions, but and it can present anywhere in the body. But usually, we do not mention oral things there. Okay, so options were condyloma acuminata. What was the question? For what? Which question options were condyloma acuminata? White lesion. Okay, so one of you is telling me that was probably a surgery question. Okay. They were talking about Peyronie's disease, then obviously you'll see it in surgery. Right. So anything apart from that that we missed? So, so I think you would have done well, at least in dermatology, and I hope the same for other subjects as well. And wish you all the very, very best for your results. And lesion on penile with oral lesion and other options for peroni, condyloma acuminata, lichen sclerosis. Okay. Ulcer. So you see again, lichen sclerosis would usually not present with an ulcer. You usually see atrophic white patches in the genital area in lichen sclerosis. It's rare to see ulcers with lichen sclerosis. Okay. Right. So I think we leave that question here, there. And any other question which you think was there? So, yeah, you're right. If syphilis was there, syphilis can explain everything, but condyloma acuminata is not syphilis. Ulcer on penis, chin, and oral mucosa. So, even lichen planus can present with such lesions, genital lesions, oral mucosa lesions. So I'm so sorry, but I'm not getting the exact question, and so I'm not able to tell you the exact answer here. So if you are able to jot down the exact question, I would be happy to help you out there. But as the ulcer on the genital area with oral mucosal lesion, lichen planus can also be there, syphilis could also be there. But what was there in the question would be more important then. Right. So I think that brings us to the end of this recall session, and have a nice night and day. Take relax and enjoy.